Ma'am, you can start.
Uh,
Good evening, everyone. Welcome to today's IN INOS combined webinar. And I'm very grateful to all of those who have joined in. At the very outset, I thank the office bearers of IN, Debashish Chaudhary and Meenakshi Sundaram, Professor Meenakshi Sundaram, both of whom have been taking, proactive steps to up the pedestal of IN in different domains, including neuroophthalmology. I thank the office bearers of INOS, Dr. Naveen Jayakumar, Dr. Ambika, Dr. Rohit Saxena, and Dr. Rashmin Gandhi, who have been kind enough to agree to this combined webinar. So basically, this webinar is to highlight and discuss a few common issues that we often encounter in our day-to-day clinical practice. So before I hand over the proceedings to Astha to do the needful, I just have one sentiment to echo. I was in Nanos a month ago, where I was an invited faculty on neuroophthalmology, obviously. And I noticed that we share the same pedestal in terms of intellectual capital as they do. The difference is that they try and document whatever they see. A, B, they are exceptionally good at marketing themselves. I think these are the two important aspects of our practice that we need to pay heed to. We need to document whatever we see. We need to try and publish whatever we see. And we need to, be part of the mainstream of global neuroophthalmology if we have to make a dent and if we have to change world opinion about Indian neuroophthalmology. My request to the INOS office bearers would be simple and straight. Try and involve as many IN neuroophthalmologists as you can, so that those individual silos melt into a unified silo with a trajectory that is moving ruthlessly forward. That's how you can create a neuroophthalmology power engine. And I can assure you that the day that happens, there won't be a speed limit. I'm telling you, it will be a power engine without a speed limit, because there is so much of clinical material. There is so much of intellectual capital. It's just that it's not being, it's not being harnessed in the proper manner. This combined meet is one simple, small step in that direction. I hope this is a small beginning, but will be a giant leap for Indian neuroophthalmology and will catapult us onto the global pedestal. With that, I hand over the proceedings to Dr. Astha. And Astha, over to you. Thank you so much for ensuring that this, this meeting sees the light of the day. As you probably know, she does all these things. And, she is, along with Karthik, making a fantastic difference to neuroophthalmology in the Indian context. Over to you, Astha.
Thank you, sir, and good evening, everyone. Welcome to the first combined INOS IAN webinar. Sir, at the onset, many thanks for being a constant source of inspiration, specifically in neurology and neuro-ophthalmology, not just for me, but I'm sure for all the young neurologists, all the young physicians and neurologists. So with this, we'll begin today's webinar. And the first talk will be taken up by Dr. S. Ambika. Ma'am is head Department of Neuro-Ophthalmology Services in Shankar Nethralaya unit, which is a unit of Medical Research Foundation, Chennai. She's also the vice president of INOS, that is the Indian Neuro-Ophthalmology Association. Her areas of interests are neuro-ophthalmology, and she's done various observerships, and she's an author to various index journals. Ma'am, over to you for your first talk. And before, as Asmita was requesting me, I'll just quickly introduce the other speakers of the afferent section, which are Dr. Basavraj Tigari, After Dr. Ambika's talk, Dr. Basavraj will be taking up a case of visual loss, which was a diagnostic dilemma, which will be followed by a panel discussion. And the speakers the panelists would be Dr. Rohit Saxena, who's again a neuro-ophthalmologist in All India Medical Sciences, Delhi. Sir is also also the secretary of INOS. Along with Dr. Rohit Saxena, in our panelists would be Dr. Sujit Kumar. Dr. Sujit Kumar is a neurologist, well-known neurologist in Bangalore. He's a senior consultant and epileptologist at the Comprehensive Epilepsy Management Center, Apollo Hospitals. Along with Dr. Sujit and Dr. Rohit Saxena, we have Dr. Virinder Sachdeva, who's an ophthalmologist, who's a neuro-ophthalmologist in LV Prasad Eye Institute in Vizag. And we have Dr. Karthik Vinay Mahesh, who's an assistant professor of neurology in PGIMR. With this, ma'am, I shift over the mic to you for your first talk on spectrum of optic neuritis.
Is my screen visible?
Yes, it is, ma'am.
Okay. First of all, let me thank the organizers, Dr. Asta, Professor Lal, and the team of IAN for having this, as Dr. Lal said, a big step in a conjoined webinar. And I'm going to start the webinar with my first talk, Spectrum of Optic Neuritis. I don't have any financial interest in any aspects of this talk. As we all are aware, optic neuritis can be of idiopathic infectious demyelinating association, ranging from MS, NMOSD to MOG. It can be of any background, but the only manifestation can be an acute vision loss. The typical optic neuritis, as book said description, is mostly painful, mostly unilateral, but could be bilateral too. And most of the conditions do affect female in second, fourth decade. And the conventional ONTT trial, which has been the gold standard for the treatment, recommends the intravenous steroid therapy, as we all know, 3 to 5 days, followed by 11 days taper. And oral steroids alone is contraindicated in a setting of optic neuritis. And most of the times it can be normal or a swollen optic disc, as we see here. And the peak vision loss happens within 2 weeks, and the recovery starts with or without treatment at the end of 3rd week. And most of the time, it is a 90% recovery by 4 to 5 weeks. And this is a case of a disc edema, and it could be presenting as a disc edema or a retrovulvar neuritis. Because of the changing trends with the terminology, classification, and the treatment, I think this is high time we have to take a relook of the spectrum of optic neuritis, what we face in India. So the first thing is all swollen disc is an optic neuritis? And is all optic neuritis requiring a demyelinating disorder association? So do we think all optic neuritis need a neurological perspective is the questions which we have to address right now. So when you suspect an atypical optic neuritis, so when there is a severe disc edema, hemorrhage, and exudation, painless, bilateral, elderly presentation with a progressive visual loss beyond 2 weeks and poor response to treatment by 4 weeks, severe recurrences with steroid dependence and associated autoimmune systemic diseases, and definitely do not exclude a infectious background. So these are the types of optic neuritis what we face in the atypical form: the neuromyelitis optica spectrum, MOG disease-associated neuritis, autoimmune optic neuropathies, relapsing inflammatory optic neuritis, or a steroid-dependent crayon, and optic neuritis with systemic diseases, which can be ranging from autoimmune to granulomatous spectrum, and infectious optic neuritis. We all are not new to this classification of optic neuritis, which can be with MOG, with aquaporin, and multiple sclerosis, which is the conventional typical optic neuritis. But ever since these two antibodies have come into the literature, it has revolutionized the way we look optic neuritis. So MS-associated optic neuritis is generally in a younger age group with female preponderance, and it can be associated with bilateral involvement, but the steroid dependence is not that high, and it usually has a short signals on the optic nerve, whereas that of a MOG is usually in 3rd decade with female preponderance, frequently bilateral, and severe vision loss is quite possible, and bilateral involvement, and it is highly steroid dependent, and the risk of blindness is not that high as compared to the NMO group. And they have a long anterior optic nerve signals, unlike the aquaporin type of optic neuropathies or optic neuritis, where they have a long posterior optic nerve involvement, and the chiasm involvement is quite frequent in the NMO group of optic neuritis, and it usually presents a slightly elderly age group as opposed to the other two groups. So the ophthalmic manifestation of MS, it's only 20% of MS is an optic neuritis, but we have a huge other spectrum of ophthalmic manifestation. But we would stick today with only optic neuritis. And MOG optic neuritis, as is well known, it need not only cause an optic neuritis, it can cause myelitis, and it can also cause multifocal CNS demyelination and ADEM, which is very commonly seen in the pediatric age group. MOG optic neuritis is bilateral, recurrent with severe disc edema, and classically it has a perineural enhancement on the MRI than the demyelinating optic neuritis. It can affect any age group, and usually it presents with severe vision loss, but it is having a better response to treatment than the NMO spectrum optic neuritis. So this is the latest proposed MOG diagnostic criteria by the international experts by Brenda and Banwell et al., where they have made the clinical demyelinating event could be one of this with a positive MOG test and excluding the MS. These are the main criteria how we look in making the diagnosis of MOGDA. So this is just done to ease out the way we identify this MOG-associated optic neuropathies and the management concerned to it. And we are not new to this IPND criteria of NMO in making the diagnosis of NMO. The absolute criteria is being a neuritis and a myelitis, whereas the supportive criteria could be the imaging, card finding, and the seropositive status. As explained earlier, NMO-associated optic neuritis usually causes posterior optic nerve involvement with chiasm, and bands are negative, and NMO antibody is usually have to be done in recurrent and poor visual loss optic neuritis, because this is the group of optic neuritis which requires a chronic immunosuppression, and definitely a patient who is negative to this antibody but having a poor visual outcome has to be refrained by using this disease-modifying therapy of MS, because it can be either ineffective in them or it can in fact cause worsening. That's the another earlier type of optic neuritis classification, whereas this Lancet 2022, Axe, Petzold, and Clare group have come up with this latest classification of optic neuritis, where they have tried to anatomically segregate the optic neuritis into different patterns. Basically, the clinical criteria, paraclinical criteria are being used to group them into definite, possible, or not optic neuritis. So here the group A is the typical optic neuritis, whereas the B and C are the atypical one. They have used structural OCT findings, imaging characters, and the seropositivity as the paraclinical features. This is something which is latest in the classification of optic neuritis, and we are yet to see how it is going to be taken worldwide across in the treatment of optic neuritis. So coming to the treatment, if it is a single attack of optic neuritis, a monophasic event, intravenous steroid therapy is the recommended ONTT protocol. And if we get a good recovery, we usually follow them up, and provided there is no neurological features or imaging features where we have to be worried about. But if the recovery is not good, the patient comes with the recurrences, or if there is a seromarker evidence, or if they take any of this possible route, you have to consider the next line of management, which can be an IMA modifying agents in case of an MS, but it is a strong immunosuppression when there are these seromarkers positive. But we have a type of optic neuritis where they may not be having classical MRI or clinical features of MS or NMO-SD. So you have to be very cautious in treating this group of optic neuritis, particularly when they don't have a good recovery. When there is an increased relapses which are steroid dependent, maybe even if they are seronegative, we keep them as a MOG type of neuritis. But when there is a progressive visual loss, always better to treat them as a seronegative NMO spectrum disorder. So these are the major groups of demyelinating neuritis. And invariably, the acute treatment is an intravenous steroid therapy, which is going to improve and fasten the recovery. And it is recommended in all the groups, provided in MOG, if the early steroid therapy is not that adequately causing an improvement, Plex can be used when the response is poor. And NMO-SD, there is no second thought, Plex has to be pushed earlier. And the disease modifying therapy has a role only when we suspect MS type of optic neuritis, and it doesn't have any role at all in NMO-SD. And immunosuppression and MOG-associated neuritis, yes, may be indicated. Particularly, a chronic immunosuppression is needed when there's a high relapsing rate. To maintain the vision, to maintain the immunosuppression, we may require immunosuppression for a chronic period. But in NMO spectrum, we have to invariably give a chronic immunosuppression to prevent further visual loss. This article by John Chen et al. Has compared the use of plasma exchange for optic neuritis, and it found that old age, delayed treatment, and poor vision on presentation are poor response predictors, and even MOG less than 1 month had a very good outcome with Plex. So coming to the chronic treatment, this group compared the use of rituximab on MOG-associated neuritis versus NMO-associated diseases, and they found that definitely rituximab had a very good response with the NMO spectrum rather than the MOG spectrum. And the other steroid-sparing maintenance are being studied as it is shown here, where MySet, Ritux, and ASA scored very high, and they had a really better annualized relapse rate compared to the other one. As I mentioned, rituximab had a very good response with NMO spectrum than the MOG. And Chen also studied this international multicentric trial of IVIG as a maintenance for few of the patients of MOG. And they found that the ARR was much better with repeated courses of IVIG in them. And there are lots of newer drugs for MOGDA, but I don't know, they're quite expensive. And when they have only isolated optic neuritis, they may not be very much useful. But when we look at the Indian literature, you have to be very careful, because we should not look at the Western literature, because this is the type of population what we are treating, and our people are paying from their pocket. We don't have an insurance system. So imaging to immunosuppression to immunomodulatory agents, we have to be very cautious in what we are choosing and advising, because that may be the last day. If it is highly expensive, the patient may not turn up. Apart from the increased populations, we also have a lot of looming infections in our country. So we have to be very cautious when we are going to take a step of a higher and stronger immunosuppression treating for the optic neuritis. So this is an interesting article in the literature where they found this demyelination registry concluded that optic neuritis in India is similar to the West, and almost 50% of them developing in MS in the long term. This is something in the literature, probably from a demyelination registry. But when we looked from the ophthalmic perspective, these are few short studies which have been in the literature, where this Delhi group, and this is our study, where we found that the age, female preponderance, disc edema, pain, bilateral incidence, everything is matching to this group. And we had only 5% of them by 3 years. And in fact, recurrence was more common in retrobulbar neuritis. And this is our study where we tried for the seromarkers role in optic neuritis. And then we found that MOG optic neuritis had a higher tendency in our group. Equally, a double negative optic neuritis was also high, whereas the MS and the NMO spectrum was slightly less. And when we saw the treatment pattern, the MOG optic neuritis had a better visual outcome than the NMO spectrum disease. As I mentioned, the double negative also had a better relapse and response to treatment. And this is another article where we tried to analyze the status of NMO antibody in our severe optic neuritis patients. And we found that it had a definite role in recurrent optic neuritis and those with poor visual outcome and the bilateral ones, because and also we concluded that the seropositives were mostly female, had poor visual outcome, and these are the lesser chance to move into MS, and we have to refrain them from an IMA, and it's better to move on for early immunosuppression in these groups. So let me go few case examples as we see in our clinical practice, because we all have a sufficient knowledge about the neuritis, but its implication is the key. So this is a case who is a 17-year-old girl who came with sudden loss of vision in both eyes during her board examination. She had a normal anterior segment, fundus was normal, and then she was diagnosed as malingering and referred by the local doctor. On examination, she had a bilateral hand movements, close phase vision, and she had a sluggishly reacting pupil with no relative afferent defect and a normal fundus. So here, the VEP was useful. It showed that delayed latency and a reduced amplitude. So it is not a malingering. That was a bilateral retrovalvular neuritis. So she was ordered for MRI brain in orbit, which was normal. She was treated with IV steroids and followed with an oral traper. And 2 weeks down the line, she improved to 618. And 1 month down the line, she improved to 6.9. But still, she remained to have a defect of color vision and a persisting central field defect in both the eyes. 4 years later, the same patient came back for a follow-up when she told that she had a good vision. She's moving up in her studies, so she wanted to come for a routine ophthalmic evaluation. And she still had a central defects in the fields, which was not very comforting for us when we analyzed her ophthalmic findings. But she gave a history which really was very, very important from the neurological perspective, where she had a loss of sensation, unable to hold objects right, and she also had a poor bladder control. So we said, like, better you get her MRI brain and orbit repeated. And this is what we saw in the repeat MRI, florid lesions around the periventricular lesion. And they were the classical Dawson's. And in fact, she also had small signals along the cervical cord and down the dorsum. Her OCB was negative in CSF. She was negative for the seromarkers. She was put on interferon, and her last review was 6.6N6, and she still had a poor color vision. So that was a case of an MS-associated optic neuritis, where she started with an optic neuritis, but ended to have a MS spectrum. This was a known case of relapsing remitting MS. In fact, she was referred by the MSSI for a routine ophthalmic evaluation, and she was on interferon when we saw her. And she also complained of 2 episodes of mild vision drop. She was a wheelchair bound because one of the earlier attacks, she started having a severe tremors and walking difficulty. And this was her ophthalmic finding, her vision normal, color vision normal, discs were relatively good, fields normal. As a part of the routine workup, we ordered for the blood picture, and she had a previous report of ELISA of NMO antibody, which was negative. But when we repeated with a cell-based assay, she was positive, but she was on interferon and she had relatively good OCT. But I told her and gave a note that she is positive for NMO and maybe we may have to rethink her diagnosis. And suddenly she came back with a drop in vision in both eyes with painful drop. She had a dense 618 vision and a dense inferotemporal defects in both the eyes with a temporal pallor. So when we repeated her MRI, we saw a significantly thickened chiasm apart from white matter lesions in corpus callosum and the posterior chiasm. So that was a chiasmal neuritis, and that's very characteristic for an NMO-associated optic neuritis. So she was stopped on IMA, and after the IV steroid, she was switched to rituximab, following which she stabilized in her vision. And she was also, after that, she was moved to a oral azathioprine. So this is another female who was referred to us with complaints of sudden drop in vision in the left eye. She was very symptomatic, but 6.6N6. Pupils briskly reacting, no relative defect, and that's the fundus. VEP normal, color vision normal, fundus normal. So the husband told now that she's malingerer. So the fields told that she's not a malingerer. She had definitely a huge enlarged blind spot on the left eye. And what we MRI normal, FFA had a normal filling, and the OCT also had a relatively normal RNFL thickness. So what we had in that patient was an acute idiopathic blind spot enlargement. All we have to do is no steroid and no further fancy medications. Just watch her over a period of time. That's 4 months later, and that's 10 months later. So how to investigate an optic neuritis is $1 million question. I think we are going to have it down the line in this webinar. And here I would say that before you think of the investigations, talk to the patient. History taking is the most important key, because the tempo of the vision loss is going to give a clue that it is an optic neuritis. Optic neuritis has a rapid drop in vision, but has a sustained recovery and reaches a plateau, unlike the other optic neuropathies. That's a gradual, progressive, compressive, and that's a further worsened neuropathy, ischemic etiology, which doesn't improve as a optic neuritis. So these are the list of optic nerve function tests which we routinely ask, and we have a lot of ophthalmic tools which will help us, starting from electrophysiology to OCT to visual fields. But the pupil doesn't have any less value in evaluating. If there is a bilateral dysfunction, we always see a sluggish pupil, unlike a unilateral dysfunction where we see a relative afferent effect. So the visual fields can be inferior, dense central scotoma, or an advanced field loss. But most of the time, always we do pick up a subclinical event in the fellow eye on a visual field assessment and a color vision assessment. OCT is the much sought investigation in ophthalmology, or rather even in neurology of late. And that is the tool which gives us the structural value of both the optic nerve cube as well as the macular cube, because the RNFL thickness and the inner ganglion cell IPL thickness plays a vital role in most of the neurological diseases. So the RNFL loss occurs in eyes with patients of MS quite earlier, and the optic neuritis will accelerate the RNFL loss, and 75% of them will lose 10 to 40 microns of the RNFL within 3 to 6 months of their acute event. And RNFL measured less than 75 microns will correspond to the decline of the visual field linearly, and it has a higher tendency to affect the temporal quadrant, unless the NMO, which has a preferential involvement of the vertical quadrants, and the thickness loss can be quite severe in an NMO spectrum. It can go down up to 50 microns, and that has to be done in all patients with a event of optic neuritis. Of course, there is no doubt that MRA brain and orbit has its vital role in the evaluation of an optic neuritis. With proper cuts and adequate contrast, flare sequences, stir sequences, and a DWI analysis will be useful in pinning down the type of brain lesion which is associated with the optic neuritis. And CSF analysis can show increased cell count, total protein elevation or IgG, and oligoclonal bands can be picked up in the condition of MS. And VEP has a role vital, particularly when we are seeing a retrobulbar neuritis. So this is the pattern of the involvement. The MOG spectrum has mostly an anterior long involvement, whereas the NMO spectrum has a posterior and a chiasmal involvement. And MS can also cause, but it may not be that long compared to the other conditions in the setting of optic neuritis. So the blood investigation, the conventional teaching is typical optic neuritis doesn't require a blood test or a CSF analysis, but now there is a way of re-evaluating that concept. There are conditions where we may need blood investigation even in the first event. That has to be case-based. And these are the list of blood investigation which we routinely perform, and that can be elaborated based on the patient presentation. This is a 66-year-old female who came with a sudden drop in vision in the right eye. It was painful over a period of 3 days duration. She was a known diabetic hypertensive and no features of giant cell arteritis or no features of ICP. She had a severe vision loss, counting finger closed face with a relative defect. And this was the optic disc appearance. You could see a blurred margins with a hemorrhage, and that of the left eye was normal. And as a part, when we evaluated, she had ill-defined deep periventricular lesions, and we suspected it could be ischemic ones, but there was also a curvilinear lesion, a hyperintense signal along the splenium of the corpus callosum. So when we did the blood investigation, and because we had to put in that age group a course of steroid, we routinely perform a HRCT which showed hilar adenopathy. And then she turned out to have MOG as well as a quantiferon positive. And she was negative for all the spectrum of blood tests. So she was referred to a ID consultant. We did a neurological evaluation, got the CSF, and there were no infective etiology associated. But with the ID consultant opinion, we put her with the steroid, also started her on antituberculous treatment. And 2 weeks down the line, she improved to almost pinhole 6-9 with a good recovery of the color vision also. And by 1 month, she had a good recovery in that vision, and this was a visual field. So that was a MOG neuritis with an overlay of TB under the treatment, with the antituberculous treatment. So this is a 30-year-old male who is my last patient. He is basically a pediatrician by profession. He came with a sudden drop in vision in the right eye. 3 months back he had. He was locally diagnosed as optic neuritis and treated with intravenous steroids and oral steroids. He had 2 episodes of worsening whenever he came down on steroids. He had an extensive blood workup according to him, which were all negative, including a MOG and an NMO. But his only question he shot me was, I wanted to discuss whether am I having an MOG optic neuritis, because whenever I come down on steroid, I'm getting again an attack. But brilliantly, he gave another history that he was also incidentally found to have been positive for HIV and he's on heart therapy. So his vision on examination was 618 with a relatively good color vision, but he had an insignificant vitreous cells and left eye was normal. So this is the fundus appearance where you can see that there's a subtle temporal pallor, but that's definitely an unhealthy macula, what you can see on with a central defect, and that of the left eye fundus and the fields were normal. His imaging was also subsequently normal. And when we did the OCT, he had a fairly normal RNFL thickness, but OCT of the right fovea showed few RPE defects. And the fundus autofluorescence image showed tiny hyperfluorescent dots around the macula, and the AF images showed hyperautofluorescence pattern at the macula. That showed that there's definitely something going on at the macula. When we repeated the blood evaluation, his CT was fairly on borderline, and ANA was positive, and he had all the other infective parameters negative. Ultrasound, no evidence of T sign for any posterior scleritis or any other uveitic entities. ERG and others were normal, and tests for TB were negative, but then this turned out to be positive. So he was positive for syphilis. He was TPHA positive, and he's already a HIV positive patient. So we involved the ID consultant in the loop. We started him on penicillin therapy. Along with that, we put him on a course of steroid, and by 1 month, he maintained 6/6 vision with the normal fields. These was his fields by 1 month. What he had was a neuroretinitis with probable early posterior placoid chorioretinitis, which is because of syphilis. So here he had HIV with syphilis, and that was the reason why he was having that relapsing type of vision loss, which was partly painful. So we have to be very careful. And syphilis is a great mimicker. It can mimic as any type of sudden vision loss. Unless it is evaluated, we may miss it. So to conclude, not all swollen optic disc or optic neuritis. We have to differentiate them clinically from all the type of optic neuropathies, what we see. Watch for the red flags of demyelination, and always remember we are in India. We have a lot of infections around us, and particularly when we have to put the patients on chronic immunosuppression, you have to rule out them. And MRI, brain and orbit and OCT will have their vital role in the management and coming to the prognosis of the optic neuritis. But good history taking and a careful ophthalmic evaluation is always a need, and a proper follow-up of optic neuritis will help us to see what is the natural history of that particular neuritis. And MOG and NMO antibody screening has become invariably very vital in a setting of optic neuritis, most importantly in recurrent and severe optic neuritis. With that note, I also would like to invite you all for the 6th annual Indian Neuro-Ophthalmology Society conference, which is going to be hosted by Shankar Nethralaya on September. The registration for abstract submission is open. Thank you so much. And that's my team way back in Chennai. Thank you, IAN, for this opportunity.
Thank you, ma'am. Thank you very much. I think that was a wonderful talk. And I think thank you for getting up for those patients of the MS and NMO outliers, and also to get up that wonderful burning question of TB, MOG and NMO. I think there were so many questions down there in Q&A, which we'll be taking up in the panel discussion part. For now, I think we'll quickly move on to the next case. An interesting case of which was looking like optic neuritis to begin with, which will be taken up by Dr. Basavraj. As I told some time back, he's a faculty in ophthalmology, taking care of neuro-ophthalmology part in PGIMR Chandigarh. Dr. Basav, over to you.
Thank you, ma'am. Just 1 second. My slides are visible, ma'am?
No, they aren't visible. Asmita, can you help her?
Yes, sir, can you go back to Zoom? And there is a small icon of share screen
Yeah.
below your screen. Just click that.
Share.
Share screen, the green icon.
It's asking me to open the system settings.
So probably your system has not allowed the share screen. You have not given the permission.
So what should I do now?
Go to the settings.
Okay.
Yeah. And allow all the permissions.
Now my slides are visible, madam.
Your screen is visible, Dr. Basav.
No, ma'am.
Asmita,
Yes,
can
yes.
you mention?
Yes.
Yes.
Yeah. Can you move
Yes.
slides? Yeah, perfect. Go back to the first. Yeah, you can start the session.
Good evening, respected teachers and my colleagues. I would like to thank the organizers for giving me this opportunity. Without wasting much time, I will directly move on to my case, a case of visual loss, a diagnostic dilemma. So this is a 44-year-old female who was a housewife, and then she was referred from neurology for the evaluation of decreased vision in the left eye from last 10 days. The diminution of vision was gradual in onset, painless and progressive, and it was associated with headache. There were no exacerbating or else relieving factors. There is no history of redness, pain, or watering. There is no history of any associated vomiting. So the past history revealed that like she had a hypothyroidism during her pregnancy. Currently, she's on off medications. No history of diabetes and other things. Personal history, she gives an important history of increase in sleep as well as the decrease in the appetite. That is one most important history in the past history. Family history, her father had a CVA some 5 years back. So again, like she was treated in neurology during the month of June in 2021. She had carried her MRI films. Like she went to neurology department for dull aching headache for 3 months, a sense of imbalance while walking. So the neurology people admitted her, and then they did her CSF analysis. The CSF analysis was normal. The MRI shows a flare hyperintense lesion in bilateral cerebellar hemisphere, left more than the right, without any mass effect, which shows a contrast enhancement. It was in the June 2021. Again, the patient, she was treated supportively, and then again the MRI was repeated in October 2021. Again, the patient had a mild improvement in her imbalance while walking. There was no associated headache. There is no associated any visual field effects. Following follow-up image, the MRI image shows mild enhancement of the pituitary, and other normal hormonal workups was within normal limit. So again, like the patient came to us like the painless and progressive diminution of vision in the left eye. So over 1 week period of time, like she went to the neurologist again. They referred to ophthalmologist. The MRI repeated, and the baseline workup was done. Again, the CSF analysis was done. Everything was within normal limit. Nothing like all the lab reports were within normal limit. The MRI shows there is a pituitary enhancement. The pituitary gland shows contrast enhancement. The meninges lining the brainstem as well as cerebellum shows a nodular contrast enhancement. The coronal section shows the contrast enhancing deposits in the floor of the third ventricle. So when we examined the patient in advanced eye center, the right eye showed best corrected visual acuity 6/5. The IOP was within normal limit. The fundus was absolutely fine in the right eye. In the left eye, the visual acuity was 6/18. There is no RAPD. The IOP was 16. The anterior chamber was quiet, and the fundus photo shows a media clarity of grade 1 to 2 with a mild vitritis. There is a disc edema along with a peripapillary hemorrhage, and then there was a well-demarcated, ill-defined retinal thickening, especially in the peripapillary area, more in the superior aspect compared to the inferior aspect. Moreover, the blood vessels, when you see the blood vessels, especially this in the magnified view, we can clearly say that there are some perivascular cuffing, especially in the posterior polar area. The perivascular cuffing was more enhancing. So it suggests like it's a morphological. It suggests that like it has a morphology of candle wax dripping, which might be most commonly seen in case of sarcoidosis. So this is the left eye fundus picture. So the autofluorescence did not reveal much information except some hyperautofluorescent lesion over the posterior pole. So the OCT macula showed some kind of vitreous cells, like in the vitreous cavity, it shows some kind of vitreous cells. The inner retinal layers are disorganized just next to the disc. There are some intraretinal, especially in the outer plexiform, there are some hyperreflective deposits were there, which are suggestive of a hard exudates because of resolving macular edema and other issues. There were no sub-RP deposits except the except the photoreceptor layers were disrupted here. The choroid was absolutely normal and then it was uniform. There was no granuloma. There is no irregular enhancement in this OCT. So this is just a magnified picture of that thing. The other scans of the OCT shows the similar picture. In this slide, we can clearly see that the vitreous cells are quite remarkable in this. So we repeated the angiogram. The right eye angiogram was absolutely within normal limit. The left eye showed like initially the lesion, the peripapillary lesion was hypofluorescent, and then in the later phase it started like hyperfluorescent, and then there is a leakage of the disc. And then other than this thing, like the most important thing is there is a diffuse vascular leakage is there, especially in the posterior pole, which is suggestive of a vasculitis. So the baseline investigation was done. Again, all the baseline investigations are within normal. We suspected sarcoid granuloma with a vasculitis. That is the most morphological diagnosis, like by seeing the morphology of the eye, we suspected that thing, and then the workup for the sarcoidosis came normal. So we kept a differential diagnosis, neurosarcoidosis, and then neurology consultation again taken, and then we discussed the case, and then we started the patient on IV methylpred 1 gram for 5 days. The improvement in the ocular symptoms was noted. The left eye visual acuity was improved to 6.9, and there is a resolution of the. I'm sorry for this follow picture. The lesions were completely resolved. So this is the autofluorescent picture where the hyperautofluorescent lesion around the disc was reduced, and the fovea was absolutely fine. Around the perivascular area is also within normal limit. So in October 22nd, October 2022, she had again the recurrence of headache. The MRI repeated again because of recurrence in the headache. The pituitary lesion was almost similar to July 2022 MRI. The recurrence of headache on tapering, the recurrence of headache was on the tapering dose of Vislon to 10 mg in October 22, and then it has increased to 40 mg for 2 weeks. Just after increasing the 40 mg to the steroids, like the headache was resolved and the mycophenolate mofetil was continued. So this is like just like a comparison picture. This is October 22nd photo, and this is the autofluorescence, and this is the corresponding OCT. It shows that all the presenting features which were present in the May month were completely resolved. So again, the patient was followed up. Again, she presented with us like with multiple subretinal hyperreflective, multiple subretinal yellowish white irregular fuzzy marking like choroiditis like lesions were present, like, which were not there in the May. The corresponding autofluorescence shows the typical central hypoautofluorescent, and then the peripheral part of the lesion shows hyperautofluorescent lesion, typically suggestive of some kind of leopard skin appearance in the autofluorescence. The oral steroids were stopped, and then the symptoms were recurred. Again, we consulted the neurologist. Again, the oral steroids were hiked, and the lesions were started healing. So this is the September. This is the October. This is the last follow-up picture. Like when the lesion started becoming normal. Again, the patient had a recurrence of headache. In January 2024, the patient presented with fever and generalized body weakness. The MRI suggested primary CNS lymphoma was suspected, and the CSF analysis was performed. Before this thing, the patient again complains with the worsening of the imbalance, somnolence, inability to identify the family member, severe ataxia, bilateral lower motor neuron facial paralysis. The MRI shows these hyperintense lesions, especially in the temporal as well as the parietal lobe. The CSF cytology shows large atypical cells with independent opened up chromatin. These cells were CD20 positive and then CD3 negative, suggests that like these are B cell lymphomas. So the PET scan was repeated. The PET scan was ordered to rule out any metastasis and other things. The PET scan was there is no abnormal uptake in the extracranial except the pituitary enhancement was there. So finally, we made the diagnosis primary non-Hodgkin's B-cell CNS lymphoma with a vitreoretinal lymphoma. So with the help of medical oncology consultation, we started on De Angelis protocols. The patient was treated with all the chemotherapy, and then the patient became sick because of chemotherapy and other things, and she is still admitted in ICU. So because of that thing, like we are not able to treat or we are not able to follow the eye lesions. So discussion, ma'am, that's the last two slides, ma'am. Most important thing is the cytology. In 45 to 50% of the cases, it can lead to diagnosis. That is most important. The immunohistochemistry, cytokine analysis, molecular analysis, and then other like MYD88, and then
2 slides for discussion of the questions also.
L26P mutations. They are helping us to achieve the diagnosis as early as possible. Similarly, the CSF analysis is also going to help us. So this is the last slide, like the lymphoma treatment or protocol resume. The combination therapy has much better value compared to the only a systemic or else local ocular treatment. So this is just I copied it from the literature. So thank you.
Many thanks, Dr. Bassa, for finishing it within the next 2 minutes. So because we were running a little late, so I think we'll directly go on to the panel discussions. I've already introduced the panelists to our audience. The panelists for today are Dr. Sujit Kumar, Dr. Virendra Sachdeva, Dr. Kartik Vinay Mahesh, and we'll also have Dr. Professor Lal in the panel, and we'll have Dr. S. Ambika and Dr. Basav Raju who are the speakers for the A-Friend section. I'll directly go up with some questions. Maybe we can initially just take a few questions with Dr. Sujit. Sir, as a neurologist, I mean, should a CSF tap, NMO, and MOG antibodies be done in all patients in all episodes of optic neuritis? How do you do it?
Well, a CSF analysis is important in optic neuritis per se. I'll answer it in 2 parts. One is about the importance of doing a CSF analysis. Very often, CSF analysis helps us to confirm that it is not an non-infectious kind, I mean, an infectious kind of optic neuritis or due to some other infiltrative form of optic neuritis, such as we see with malignancies. Sometimes we see optic neuritis-like picture arising from adjacent fungal sinusitis, or even from carcinomatous meningitis. So doing a CSF is very important. And whether to do NMO-MOG antibodies is also, I would probably analyze it based on the clinical picture of the patient. So whether it's a bilateral optic neuritis, whether the optic neuritis involves a chiasma or more than half the length of the optic nerve, all these things will have to be taken into consideration when we ask for NMO-MOG antibodies. If somebody has a typical history of a fever preceding the optic neuritis, or typical MS lesions on the MRI, then probably I wouldn't do the NMO-MOG antibodies. And once the diagnosis, I mean, we have actually gone through a very great talk by Dr. Ambika detailing the different criteria for NMO spectrum disorders, including NMO, ST, and MOG associated disorder. So if you meet the diagnosis, it's certainly not necessary to repeat the antibodies at a later level or even do the CSF if there's a relapse. Unless clinically, sometimes, as we've seen, Professor Lal shows so many cases wherein other things can also can get involved in a case of NMO-MOG disorder. So unless we have a suspicion of something else contributing, we need not repeat the antibodies or the CSF analysis in subsequent relapses. But of course, the idea is to prevent the relapses, so we shouldn't have too many relapses.
Yes. Ma'am, Dr. Ambika, ma'am, do you follow up these antibodies for treatment purpose, like after 2 years, after 5 years, before stopping the medications, specifically the disease-modifying therapy? So, do you think these antibodies can be helpful at that juncture, at that level?
See, actually, if I make a diagnosis of a MOG optic neuritis and I get a good visual outcome, generally we don't repeat the MOG assay repeatedly. If a patient is going to come with a repeated relapses and a fairly not an expected improvement with the therapy, probably we will repeat, because there is always explanation that MOG antibody with a very high levels will require a longer treatment. That's one of the proven thing in the literature. So MOG, maybe we may repeat, but given an NMO spectrum disease, once it is NMO positive, and I don't think I do repeat the NMO because it is going to be a NMO forever.
Okay,
And
right.
MOG alone, maybe I will repeat to see if the relapses are high, to check for the titer. Otherwise, I don't recommend that to be repeated.
Thank you, ma'am. Dr. Sachdeva, so there was some questions in the this Q&A section also, and also, would you recommend IV steroids to all patients of optic neuritis? And I'll also, along with this, take up another question which was there in the Q&A section. Which oral steroids would you prefer, Omnacotil or methylprednisolone orally, or prednisolone orally? What do you prefer, and why?
Yeah, thanks, Dr. Asa. I think it's been a wonderful talks, and Dr. Ambika already alluded to in her talk that all episodes of acute optic neuritis should be first treated by high doses of IV steroids. Oral steroids alone are going to cause a partial remission of the disease and are associated with increased risk of relapses. So IV steroids, currently most of us give for 5 days, followed by oral steroids would be the regimen. As regards giving the oral steroid, I think we still use oral prednisone, but methylprednisolone tablets also can be given, but it's easier for us to titrate and taper the oral prednisone rather than methylprednisolone. That's what I prefer.
Yeah, maybe in equivalent doses, these steroids can be used and
Yeah.
tapered off. What about double negative patients? So there was another question that what do you do in double negative? Do you also treat them with IVIG, plasma exchange, and prolonged immunosuppressive or a disease-modifying therapy?
In the first episode, no. First episode of a double seronegative disease or MOG, currently we do not give a disease-modifying drug or immunosuppressive therapy, but at the same time, we give them a tapering doses of oral steroids rather than just giving oral steroids for 11 days and then stopping. But
Yes.
if it's a relapse, then we consult the patient and then give immunosuppressive agent accordingly. Go ahead,
Thank
Dr.
you.
Ambika.
Yes.
You want to
May
add
I
something?
make a comment? Actually, in double negative patients, whatever we have seen in our setup, the ones which respond well, we just don't have to worry too much about, who don't have the imaging and the other features which makes us worrisome. They are double negative, one attack, responded, can be watched. Double negative, and that's the first attack. Response is not great, and imaging characters are not very much classical for one of the spectrum. The problem comes there, which type of immunosuppression to choose on. So those ones we always prefer to move on, and early escalation for the immunosuppression when the response is not great, and we do follow them as if the response is not good, vision loss is severe, we treat them as a seronegative NMO spectrum only. We escalate. We can push up legs earlier to them. But if the vision response is gradual in progress, maybe we can just keep a watch. You can give cycles of IVIG or a Ritux and then keep them on a chronic follow-up. But I do recommend, when the response is not great in the treatment, to better to keep them on a chronic immunosuppression, unlike a good response.
That's great point, Dr. Ambika. Like if the response of the patient is poor in a double seronegative patient, we are not sure what the underlying neuroinflammatory disorder is. So further extensive workup, spine imaging, and course of the treatment should guide us. I agree with what you said.
One question from Dr. Karthik. There was another question which was asking about CSF cytology in Dr. Basav's case. I think you mentioned CSF cytology, malignant cytology was negative in your patient initially, and somebody else has also mentioned that there was pleocytosis earlier, which was attributed to sarcoidosis. Dr. Karthik, how long would you administer these disease-modifying therapies? It's a very common question. When to stop, when not to give? After 2 years, 4 years, lifelong, how long would you recommend?
Of all the questions, this question is very difficult to answer at this point. Whether you want to give for 3 years, 5 years, that all depends on how is the patient responding. We all actually look for when the patient had a last relapse during this time. If the patient had a relapse for even on immunomodulation, I think we will have to consider minimum 3 years before you have all the memory cells being wiped out before they stop producing those antibodies. This is what theoretically it should. But usually, in our patients, we do follow up them with neuroimaging or any other signs of active inflammation. Sometimes if the patient had like MOG, as Dr. Professor Ambika said, that MOG positivity correlates with the disease severity. We can even follow up with some patients with antibody titers also. But usually guidelines don't mention for NMO, though some do mention for MOG. If the titers keep on decreasing, you can actually try tapering of steroids. But a good 3 years suppression, what we ask for 3 years or 4 years is just so that the bone marrow memory cells forget what we say, what the immunoglobulins they are producing, that is NMO antibodies or MOG antibodies or any other autoimmune antibodies. That is sort of chronic immunosuppression. And adding to the point what Professor Ambika and everyone was discussing, whether double negative antibodies, that is NMO negative, MOG negative. We have to first confirm whether this test was done on a cell-based assay or an ELISA. So both of these have different sensitivities, and cell-based assays, that is fixed ones, are more sensitive than what you have on ELISA. So these might be false negative also. And another question regarding whether CSF NMO and MOG can be done, that also has some clarification that has to be required. In patients, in a large group of patients in which they did CSF and serum NMO antibodies, around 10 to 15% of these patients only had isolated CSF involvement. So what the newest guidelines say is these have to be repeated, because it's very unlikely that your sera is not producing these antibodies and you're having these antibodies in the CSF. Very unlikely, especially in cases of NMO vis-a-vis compared with MOG.
I would also want to ask the same question to Professor Lal. So how long should we treat multiple sclerosis, or how long should we keep treating NMO, MOG syndromes as per your experience? Because I think this is one question where experience would really count and matter. So.
See, this is need to do basis. So in 1994, I got a patient of acute transverse myelitis and necrotizing myelitis. I'm talking of the year 94 when I was as an assistant professor, I had finished my DM. Because this patient had acute transverse myelitis and had nothing else. You remember at that time, there was this entity called Devick's disease. There was no NMO MOG at that time. We gave this patient steroids and we sent her home. I don't think she was given plasmapheresis. Her power was 0/5 when she came, and it was 0/5 when she left. Her son was an advocate. You see, these long experiences teach you what books cannot. Now, 2022, I get a call that there is this judge from Solon whose mother you treated before, and he wants to get his mother again. So the mother came, and lo and behold, I noticed that it is my noting that she had had a acute onset of transverse myelitis, necrotizing, was given steroids, my discharge slip, and now this time she has just come without any relapse. Now this is 25 years without any relapse, no optic neuritis, no subsequent episode of myelitis, but someone got her NMO which was positive. And so he decided to take a second opinion. I got the NMO done, again it was positive. So then this debate between the son and the treating doctor, I said this patient has not had another attack. This patient didn't have another attack. So that attack in 94 was NMO actually, and was given 5 shots of steroids, or maybe given oral steroids, I don't remember. And the treatment's over in 2 months. No optic neuritis, no myelitis. So I think it is on a need to treat basis. So if a patient is having an attack after attack, we all know that I would any day follow up a patient with immunosuppression for at least, I repeat, at least 3 years after the last attack. Now that's a question which I'm trying to answer. If you have multiple attacks, obviously we do what we have to: plex, plasmapheresis, IVIG, and etc. rituximab. But I would continue immunosuppression. I repeat this. Now this is an answer I'm giving you, the question which was put to me, for at least 3 years after the last attack. And this immunosuppression, the aggressiveness of the immunosuppression depends upon the number of attacks the patient has had. If a patient can afford, I would probably give IVIG every 3 months, or I would plex the patient every 3 months. I would give rituximab only, I repeat, only when I realize that this patient has had just an additional attack, and after that I retux the patient and I follow up. I repeat, I'm making this statement. Rituximab for me would not be the first drug of choice if a patient is having multiple attacks. For me, multiple attacks means that these patients are being brutally hammered by the immune system. And so you have to deal with the immune system in a brutal manner. You have to give IVIG, you have to plex these patients. We are getting to see rituximab failures more and more. And the lesson is, I feel, in my opinion, IVIG with or without plex, or plex without IVIG would be a better option if the patient can afford. So now, my final answer, a single recurrence, maybe I would retux the patient and keep the patient in follow-up. Multiple attacks, I am going to bombard the patient with plex and IVIG. And will give this for 3 years till the last attack is over.
Thank you very much, sir. And one last question before we move on to the next session. So Dr. Bush was asking what to do in these retux failure patients.
Cure Bush, I know Cure Bush. He was I was a junior resident. He was my senior resident. And Cure Bush has not changed a bit. I tell you, if it's a retux failure, you have to understand, retux is not God. We assume retux is God. It is not God. I would give them cyclophosphamide. I repeat, I would give them cyclophosphamide. Don't forget these oldies. Cyclophosphamide IV is very strongly immunosuppressing. It does work in NMO MOG. It did that when there was no NMO MOG at that time, and when cyclophosphamide was the only asset we had in our arsenal. So you can give cyclophosphamide. If you don't want to give cyclophosphamide, Dr. Buch, you can give plasmapheresis every 6 months. I'm a plex man. The reason I'm a plex man is, if you look at you have to look at everything. The cost effectiveness, health economics is a very important aspect of health management, and health economics means you are having healthy management. Plasmapheresis in PGI costs you maximum 2 lakhs per all the 5 sessions. Okay. IVIG would cost you anywhere between 4 to 5 lakhs. So if you have to, decide what to do on a recurring basis, any day plasmapheresis will be more preferable. Coming to the side effects of plasmapheresis, an odd patient does get hypotension, an odd patient does get aseptic, get sepsis and things like that. But they tend to be highlighted. But when someone with IVIG gets complications, it is pushed under the carpet. So I'm not a IVIG man. I'm an IVIG man. When the man comes to me and happens to be Bill Gates, I'll say, lie down, 1 IVIG shot daily every month and you will improve, right? But by and large, plasmapheresis and a poor man's IVIG called cyclophosphamide, if rituximab has failed, should be there on our armamentarium. But having said this, please don't forget, again, Astha does it very routinely and I don't stop her. Routine giving of azathioprine must be encouraged. Azathioprine is an excellent immunosuppressor. It's an excellent immunosuppressor. So I would tell you, all that you are telling me is assuming that this patient has actually been on azathioprine also, and the patient has not made it to the level we expect the patient to be on. I hope I'm clear. So these are
Yes, sir.
common problems that
Yes,
we
thank
face.
you.
These are very common problems. Virinder would know. These were the issues which Virinder did a paper on MOG in nanos, and he gave a beautiful demonstration. And I thought his paper was the best. I did not know why he never got the award. His paper was easily the best in nanos. That platform which you gave, Virinder, remember? You talked
Yes,
of
sir.
MOG and the trajectory of treatment that we need to follow with MOG, especially when there are multiple recurrences. So my take is very clear. Dr. Butch, if you are hearing me, I don't give. I'm not a rituximab. Ritux is okay. You are giving Ritux. Basically, you want to drink your coffee which is getting cold. 6 महीने कुछ करने की जरूरत नहीं. अगर 6 महीने कुछ करने की जरूरत नहीं है ना, that is not good medicine. You should be there to help the patient every month, and so I would follow up these patients with azathioprine, with plasmapheresis, and with IVIG. Ritux for me is, they give it. I mean, PGI is a Ritux center. It's a mecca of rituximab. आप देखोगे हर दूसरे मरीज को rituximab मिल रहा है with an indication. I repeat, with an indication. Nothing is done in PGI without an indication. We are the other polarizing extreme, where we will think 100 times before doing something, even when there is an indication pronto. So with an indication, they're giving rituximab. But I would wait. I would not give rituximab. I am a plasmapheresis man. I am a plasmapheresis and an IVIG man. I'm a plasmapheresis and an azathioprine man, and I'm a plasmapheresis and a steroid man. That's my way of doing things. Thank you.
Thank you for clarifying, sir. I think that was a eye-opener for many of us. As much as I would want to extend this conversation more, and as much as the questions are there, we'll try to answer these questions right away in the Q&A section, and we'll move on to the other section, which is the e-friend section, in the wake of time. And for the e-friend section, we first have a case which will be presented by Dr. Nazneen. Dr. Nazneen is Associate Professor of Neuroophthalmology at Jagannath Gupta Institute of Medical Sciences in Kolkata, which will be followed by a wonderful talk by Professor Naveen. Can we directly go up to Dr. Nazneen's talk? Dr. Nazneen, are you listening to us? Are you there? Dr. Nazneen, are you there?
Yes, ma'am.
Yes. So you can.
Yeah, yes, ma'am. Can you hear me?
Yes, you're audible. And
Can you hear me?
Yes, you're very well.
Yeah.
You can share this. So you can share your slides, please.
Yeah, just a second.
Hello.
Yeah, I can hear you. Just starting.
Yes, I request you to please wind up in 7 minutes as we had discussed.
Presentation is not opening. Yeah.
It is open. It is open.
Can you see my slides now?
Yes, I can see your
Yes,
slides. But put it on slideshow mode, ma'am.
Yes, we can see everything.
Okay, thank you. So thank you, INOS and INS, for giving me the opportunity to present in front of such learned people. So jumping straight to the case, it's a case of a pituitary macroadenoma presenting as bilateral third cranial nerve palsy, a rare presentation. So my case is a 35-year-old male who was neither a diabetic nor hypertensive. He presented to emergency department in ESIC Medical College with excruciating pain in left eye, along with difficulty in opening his left eye.
Hello. Sorry to disturb you, ma'am. Can you put it on slideshow mode?
Yeah, how to, can you?
Yeah, I can see your slides, but your PowerPoint is in editing mode. Can you put it on slideshow mode? You have to just click on the from beginning.
From beginning.
Yeah.
I can't see any. I don't see any icon on my this thing.
On the top right corner of your PowerPoint, you see a logo which states from beginning. Yes, where your pointer was going. Just beneath it, you can see from beginning. Yes, yes, just below that. Yes, see.
No, but I cannot see anything on my screen. It's just showing my slides full screen. That's all. Should Should I press escape?
Yes, escape, exit, and then again put them from beginning.
Okay, so go to from beginning, right?
Yes. Share screen.
Can you see my slides?
No, ma'am, your screen is stopped. I'll do that. Just open your PowerPoint, put it on slideshow mode first.
So slideshow is pressed now from beginning.
Okay. Okay. Go to the Zoom window. Go back to the Zoom.
Yeah.
Yeah. Then hit the share screen button.
Yeah.
Yeah. And select your PowerPoint, which is in slideshow mode. Yeah.
I'll press Windows, right? Yeah. And then PowerPoint. And then share, right?
Yeah. Share screen.
Okay.
Yeah. Okay.
And from beginning, right?
Yes, right.
Okay.
If it is not, yeah, it's not coming.
Me?
No, ma'am, you can share as it is.
Like this?
Yes.
Is that fine? Okay. So on ocular examination, his visual acuity in the right eye was 6/6 and in the left eye it was 6/9. In the right eye, the eyelid position was normal, but in the left eye, the patient had almost complete ptosis. Anterior segment was normal except that the patient had an isocoria. In the right eye, the pupil was normal size and reaction to light was present. In the left eye, the pupil was mid-dilated, fixed and not reacting to light. In addition, the left eye was down and out. So we had a patient with complete ptosis with a mid-dilated pupil with a down and out eye. Fundoscopy was normal, color vision was normal, confrontation test was done, that was normal, and neurological examination, the motor and sensory system was intact. So now we have a young male who came with sudden severe headache and eye pain, with complete left upper lid ptosis, with pupil involved and a down and out eye. So the only thing this spells is an emergency. So this is a case of a painful pupil involved.
Dr. Nazneen, your presentation is not not seen. I think the slides are not moving. Stuck.
And below the screen.
Yeah, it's okay now.
For 80%.
Yeah.
Yeah, now it's yes, now it's okay. Now you can present it in this mode only, Dr. Nazneen.
Oh,
You
okay,
can go
fine.
back to where you were, and you can start. You can present in this mode only.
So this is a case of a pupil-involved third cranial nerve palsy. The dictum is to suspect an intracranial aneurysm pressing on the third cranial nerve. So this is a life-threatening situation because an aneurysm can burst anytime, leading to brain hemorrhage. The second differential diagnosis in my list was an intracranial space-occupying lesion. So we took the headache. We took the history again, and the patient came up with the history that he had headache for 1 month. He was hospitalized, and a CT scan was done. So a CT scan that was done 6 days ago showed a suprasellar mass with associated bony destruction. So because it was a case of a pupil-involved third cranial nerve palsy along with a sellar mass, I immediately referred the patient to medicine for admission with ICU backup and advised an urgent MRI plus MRA to rule out an aneurysm. In the medicine department, the patient was found to have an intact CNS. GCS was 15/15, and because the CT scan could be done faster than an MRI, so that was done on the same day, and it showed mildly enhancing soft tissue density, mass lesion in the sella, causing expansion of sella with bony destruction of the sella and clivus, possible cavernous sinus involvement, query pituitary macroadenoma. The CT angiogram was normal. On day 2, I examined the patient again. The left eye status was same, complete ptosis, down and out eye, pupil mid-dilated and fixed. But lo and behold, in the right eye, now the patient has moderate ptosis along with an absent function of the medial rectus. Other movements were intact and pupil was normal. So the panic mode was on. Initially, the patient came with left eye painful pupil-involved third nerve palsy, but now the patient had gone on to develop right partial third nerve palsy. So at this point of time, I suspected a lesion in the cavernous sinus. So you can see the bilateral ptosis with frontalis muscle overaction, and you can clearly see the anisocoria. And in the right eye, ptosis was present and MR was absent. In the left eye, ptosis, the complete ptosis, along with absent function of medial rectus, inferior oblique, and superior rectus. And now you can see the big mass present in the the MRI revealed a large space-occupying lesion in the body of sphenoid, involving the sphenoid sinus and clivus, pituitary gland, sella, and suprasellar extension. The pituitary gland was not visible. Visualize the size of the lesion was 48 into 46 into 38 millimeters. The mass extended into both cavernous sinus and totally wrapped around the internal carotid artery. There was effacement of the infundibular stalk. There was a mass effect on optic chiasma with distension of perioptic subarachnoid CSF spaces bilaterally and bilateral paracellular extension of the mass engulfing both the internal carotid arteries, which was NOS grade 4. So it favored a neoplastic condition of sphenoid versus an invasive pituitary macroadenoma. So other things were normal, no thrombus or aneurysm. So I urgently referred the patient to the neurosurgeon. Routine blood investigations were normal, perimetry normal, but look at the serum prolactin level. It was almost 11,000 nanograms per ml. So this was now diagnosed as a patient of pituitary macroadenoma or prolactinoma, causing compressive effect and supracellular extension, causing third cranial nerve palsy. The patient was started on tab bromocriptine. Within a few months, his headache was completely gone. Eye pain was absent. Ptosis resolved completely, and the extraocular movements became full, and the pupils no anisocoria. So you can see here the ptosis has resolved completely. The patient only had minimum mild intermittent exotropia. Pupils were normal. Extraocular movements were full. So this is the last MRI in September of 2023. The mass is reduced to almost 50%, and the mass is now 15 into 19 into 17 millimeters. So this case highlights invasive type of pituitary lesion or macroadenoma, which involved the third nerve and had involved bilateral third cranial nerves. We know that pituitary adenomas are benign tumors, and the most common presentation is headache and visual field defects, typically bitemporal hemianopsia, and painful third nerve palsy is a rare presentation of pituitary adenoma. Some macroadenomas do exhibit invasive behavior, and extension into cavernous sinus is characteristic. They can compress cranial nerves, and oculomotor paralysis, though rare, have been reported in 5 to 17% of the cases. So this is another similar case of a 43-year-old male who had a right painful pupil-involved third nerve palsy with a mass in the pituitary fossa. So Saul et al. Also reported a case series of 5 cases of third nerve palsy as the sole presenting sign of pituitary adenoma. So the mass causes a mechanical compression or interferes with the blood supply of the third cranial nerve, leading to third cranial nerve palsy. So my take home this presentation is always investigate third nerve palsy, especially those associated with pupil involvement and headache. And pituitary tumor can present as third nerve palsy. Do not miss hormonal assay, and prompt referral to neuroimaging, neurologist and neurosurgery can be life-saving and sight-saving. Thank you.
Thank you, Dr. Nazni. Thank you for that wonderful case. We'll directly go on to the discussion on how to approach diplopia for neurologists by Dr. Naveen Kumar. He's titled his talk as Double Trouble. Sir is Honorary Director of Darshan Eye Center in Chennai, and he's also the President of Indian Neuroophthalmology Society. He's a member of the editorial board of JNO, the Journal of Neuroophthalmology. Welcome, sir, and over to you.
Yeah.
Can you hear us?
Yes, I can hear you, Asta. And can you see my slides?
Very well, sir. They're very
Okay.
nice.
Okay. I just hope the slide moves, which
Good evening, Dr. Naveen. We are meeting for the first time across
hello, good evening,
on
sir.
Zoom.
Good
We
evening,
haven't
Mr.
met, so I'm so thankful that you have been
Oh, I'm
kind
happy to
enough
be
to
here.
agree
I'm
to
happy to be here.
participate in this seminar. Thank you, sir.
Okay, Asta, what are you seeing right now?
A no man's land, sir.
Perfect.
I'm
Okay.
seeing neuroophthalmology. I'm seeing neuroophthalmology. Okay.
Right. Yeah. The two phases of neuroophthalmology, Dr. Lal was talking about it a little earlier, and I was impressed by the word amalgam, perfect amalgam, which is great. But quite often, neuroophthalmology seems to be a no man's land where the ophthalmologists find it a little, the usual general ophthalmologists find it a little difficult, a little different, let me say that. And the neurologists also probably find it a little different, maybe. And I'm so very happy that we are here today, INOS with IAN at this joint session. My talk today is basically on diplopia, which I titled as Double Trouble. And I'm going to just highlight 8 simple steps to stay out of trouble. So the first question, of course, is when the patient comes to you, he's seeing double. And the first thing that we need to do is ask and do a little test and demonstrate one thing. that is this a monocular diplopia or is this a binocular diplopia? By monocular diplopia, I mean that each eye separately sees a perfectly clear image. Sorry, by binocular diplopia, I mean that each eye sees separately a clear image. But when both eyes are open, then the patient sees double vision. And that's called binocular diplopia. That is neuroophthalmology. Monocular diplopia, on the other hand, maybe when a patient closes one eye, the other eye is still having that same symptom of double vision. And the problem there is completely within the eye. So my first point is to differentiate between these two. So monocular diplopia can be due to as simple as a refractive error or a dry eye, and also cataract surgery, macular disease, etc. Cerebral polyopia is very rare. I think I've probably seen only one patient in my entire career so far, where the patient may have more than one image, 3, 4, sometimes even hundreds of it, and in both eyes. They just see it in both eyes. So you get bilateral monocular diplopia. Uh, in practice, however, I find these two objects very, very useful in differentiating monocular from binocular diplopia. When the patient is confused, generally, if you put a pinhole in front of the eye and the patient's diplopia or the blurriness disappears, then it's usually due to refractive error. And you put a little drop of artificial tears, the vision improves, the symptoms disappears, it's dry eye. Macular disease, on the other hand, if you put a pinhole, the vision will get worse. Okay, so some simple bedside or clinical test that you can do to make out this. But coming to binocular diplopia, that is, each eye separately sees an absolutely clear image, and only when both eyes are open, you see a double image. Now, here we have to consider several things. One is, what is the nature of the diplopia? Some questions that you need to ask the patient. Then your ocular motility examination, which determines which extraocular muscles seem to be weak. Then you have to ask yourself the question, is this an isolated or a multiple cranial nerve palsy? And don't forget the fifth and seventh nerve also are other nerves which are involved in this particular situation. What is the status of the lids, the pupil, and are there any orbital signs? And finally, as Nazneen pointed out, visual fields are important because pituitary tumors can also produce nerve palsies, as she showed very beautifully in that case of third nerve palsies. So let's look at the nature of diplopia, which is my point number 2. Things you ask the patient. You can ask them very simply, in which direction of gaze is the diplopia worse? Is it on the left or right, up or down? Or is it on convergence, near vision, double vision is more? Or is the double vision worse on distance vision? The point is, it tells us, the gaze tells us the direction of the weak muscle. For example, if you have double vision, if the patient is complaining of double vision more on left gaze, then it's either a problem in the left lateral rectus or the right medial rectus, because those are the two muscles that are involved in left gaze. Vergences, remember lateral rectus palsy, the diplopia is generally worse on distance vision compared to near, because that's where the lateral rectus is used for divergence. The next question you can very simply ask the patient, are the images separated? Do you think they're more horizontally separated or vertically separated? So that will tell you whether it's a horizontal recti involvement or is it either the vertical recti or the obliques. Thirdly, is it a crossed or uncrossed diplopia? That is to say, if the eye is squinting outwards, is the image turned on the other side? So that's how it works. What is the relationship of the squint to the image? So in a crossed or an exotropia, as in third nerve palsy, when the eye is turned outwards, the image is on the opposite side. In an uncrossed diplopia, which is called an ESO, like you'll get in a sixth nerve palsy, the image is on the same side as the internal. And lastly, but not the least, is it variable or intermittent? Think about not just ocular myasthenia gravis, but also thyroid eye disease, where the patient can wake up with more double vision because of all the swollen extraocular muscles when he's been sleeping, and the double vision gets better after a couple of hours. So all this, just on asking the patient some questions and doing a couple of very simple tests, you can literally find out before you even proceed further, which is the abnormal muscle. Next, coming to ocular motility, which extraocular muscles are weak, and here is a video. As you can see, this patient has a right complete ptosis. You can see her eye is turned outwards. There is no adduction of the eye. Abduction seems to work very well. Elevation is fine. And when she looks down, sorry, elevation is also affected and depression is also affected. So complete ptosis with limitation of elevation, depression, and adduction, all will clearly tell you that this is a third nerve palsy. Okay. In a fourth nerve palsy, remember that the diplopia is not horizontal, it is vertical and oblique. The affected eye will be elevated. For example, in these two pencils that I show here, if a patient is having a right hypertropia, which means the right eye is higher in position than the left eye, what will happen is, remember the superior oblique action is depression and intorsion. So the affected eye will be elevated. Opposite of depression is elevation, and opposite of intorsion is extorsion. So the eye will be lifted up and turned outwards. So whenever an eye is lifted up, the image will go downwards. If the eye is turned in, the image will be rotated outwards. Okay. So this picture is a little off, but importantly, I want you to tell you that in a real binocular diplopia, the affected eye, the second image is always a little blurry. It's not as sharp as the good eye. Okay, so if you close one eye, obviously one disappears, and just by looking at which eye the image is lower, that will quickly tell you which eye has a superior oblique palsy. I know it's a very rough and ready way to look at it, but it's a good shortcut to remember for neurologists. We do something a little more complicated called the Parkes 3-step test. I will just show you the first and the third. So this is the first step, and we ask ourselves which eye is elevated or hypertropic in the primary position, which means when the patient is looking at you. As you can see here, the child's left eye is lifted up. When you cover the right eye, the left eye comes down to take fixation. So this is a left hypertropia. So there's a possibility that the child may have a left sixth nerve palsy. And this is the third step, which is known as the Bielkowski test. What happens when we tilt the eye and the double vision? What happens to the diplopia? Okay, is it on right head tilt or left head tilt? So as you can see, this is right head tilt, and you can see that the eyes are almost looking straight at you. Okay, the right eye elevation seems to have almost gone. Let's proceed with this video. Now watch happens when he tilts his head to the left. Okay, so now that you can see this, the left eye is upshot. Okay, so this clearly tells you left hypertropia, which is worse on left head tilt. Okay, so this tells you that this is a fourth nerve palsy or a superior oblique palsy. Now, one other action, you saw the elevating effect of superior oblique palsy because because of the absence of depression. But there's one other action that the superior oblique does, which you don't normally see, and that is the intorting effect. Here, the patient just before cataract surgery, so we've given a local anesthesia, which blocks all the recti, but not the obliques. And just to demonstrate to you what is intorsion, take a look. Ask him, look down, and you can see the right eye is intorting. Take a look again. You can see the conjunctival vessels rotating inwards. So this is the kind of action I want you to remember to look at in this next video. So suppose there's a patient with third nerve palsy and you want to check for the fourth nerve. It's very difficult to look for depression action of the superior oblique because the eye has to turn inwards and for the eye to depress down. And the inward movement or the adduction is missing in a third nerve palsy. So we have to look for the rotating movement, the intorting movement of the eye. And that is best seen when the eye is turned outwards a little bit. So we need to look for intorsion in the abducted position. So take a look at this lady with a third nerve palsy. Ask her to look from up to down and keep a watch on the nasal conjunctival vessels. They will rotate. See those vessels, see that? It turns in when she's looking from up to down in the abducted position of the eye. So this tells you that she has a third nerve palsy, but her fourth nerve is intact. Now, why do we need to know the sanctity of the intactness of the fourth nerve? Because when you say if it's third plus fourth, we are dealing with multiple cranial nerve palsies, and that is a serious situation. So here is another lady with near total ptosis of the right eye. Again, there's absence of adduction in the right eye. The abduction seems to be almost full, marginally restricted. Depression is 0 and elevation is 0 as well. Let me also tell you her pupil was involved. Now I want to know whether the fourth nerve is also affected. So from up to down in the abducted position, I don't see any rotation of the conjunctival vessel. So the fourth nerve is also affected in this patient. The question is, what about that abduction? Okay, so there was a almost good abduction, but look at the speed at which the eye abducts. See how slowly it turns outwards. Just compare it with how fast the left eye is turning in, adducting. Okay, I'll show it to you in slow motion. This kind of fast movement is called a saccade. So you can see a slow abduction saccade. See how slowly that is turning out. The left eye is already in place, adducted. So a slow abduction saccade is important feature of a subtle sixth nerve palsy. This lady had obviously a right cavernous sinus SOL, and I'm sure you all guessed it by now. She had a huge aneurysm inside. Okay. So that was ocular motility, and it's our job to determine whether one or more cranial nerves are involved. I'd like to talk a little bit about the other things, which is the lids, pupil, and the orbit. So lids, for the pupil, just remember anisocoria. Okay, unequal pupil size. Sometimes it's a little difficult to make out which is the abnormal pupil. Shortcut, any pupil that doesn't work very well to light reflex is an abnormal pupil, irrespective of its size. Because sometimes anisocoria can be physiological. But in physiological anisocoria, both pupils will be reacting beautifully to the light reflex. A dull, a poor light reflex means that pupil is abnormal. Lid, don't forget to look at the lid. You look at this patient, it looks as if his left eye is got lid retraction, but actually he's got a subtle ptosis of the right eye. And not only of the upper lid, you can see the position of the lower lid in the right eye has moved upwards compared to the left eye. So there's an upside down ptosis, as a result of which the right eye is looking a little smaller, appearing to look a little smaller. So this is called an apparent enophthalmos. And if you closely look at this picture, the right pupil is relatively myotic compared to the left pupil. So this patient has a Horner syndrome. So look at the lid for ptosis for third and Horner's. Look for lid retraction for thyroid disease. Importantly, we also need to see when the patient is moving the eye in or down or up, is there any abnormal movement of the lid happening in the case of ptosis, or in case of a pupil which is sluggish, is the pupil constructing on gaze? One thing to remember, lid gaze or pupil gaze dyskinesia is never due to ischemic third nerve palsy. If you thought this patient was a diabetic third nerve palsy, kindly revise your etiological diagnosis. This patient might have trauma, or there's a space occupying lesion, and neuroimaging obviously is mandatory. So here I have a video. So I'm holding up the lid of the left eye because she's got ptosis, and you can see that she's got a third nerve palsy. But one problem is when I'm holding the eye lid, this is what I'm missing. Now I'm not holding her lid. Just look at the left lid. When she's looking down, look there, and you can see it jump up a bit. Okay, we show it again. Look at that. This little jump when she's looking down. Okay, so when she's depressing her eye, the lid jumps up. Again, now look at it. When she's adducting her eye, the ptosis becomes a lid retraction. This is a classic case of aberrant regeneration of the third nerve. This is a patient of mine who had a trauma. The right pupil is there for your reference, and you can see the left pupil is obviously there's a gross anisocoria here in the abducted position. But take a look when the patient uses his medial rectus in the left eye, okay, in the adducted position, and you can clearly see the pupil has constricted to some degree. So there is some aberrant connection between the sphincter pupillae innervation and the medial rectus innervation. Once again, this means it is a pupil gaze dyskinesias. Okay. My last point is the great mimic, which is myasthenia gravis. I think simple. If you have ptosis in a patient, makes your life super easy. Look for fatigue on sustained up gaze. As you can see, this gentleman is, you can make out he's tilting his chin up to see, and you can see more of his nose than his eyes now. But you can see how bad the ptosis has become on sustained up gaze. Now, if I lift one eyelid up, the other eye droops down. You see that? And I consequently this way. This is called a seesaw ptosis. Also a feature in myasthenia. And then when you look straight, you can see a little jump of the lid. That's called the Kogan's lid twitch sign. So all these are very, very helpful if you have ptosis along with the patient. And one simple test you can do is when the ptosis is, does the ptosis improve with the ICE test? So this was when I was working in China, and this is a patient with, as you can see, ptosis, and we put ice. The only ice we could find is an ice bottle from the biochemistry lab, but that works equally well. And after a minute of that, you can see the ptosis improves very well. So the patient is obviously very happy that he just merely used ice and his problem got cleared, and he gave a nice big smile, but he doesn't know that it's going to get worse in a few minutes later. I want to end on dangerous diplopias when we really need to wake up, whether it's the night as well. Okay. Any pupil involved third nerve palsy, the third nerve is the aneurysm nerve. Okay. Secondly, anything with orbital signs or painful ophthalmoplegia, remember superior orbital fissure syndromes like Tolosa-Hunt, orbital mucormycosis. We saw a lot of that during COVID, but also in uncontrolled diabetics. Any multiple cranial neuropathy, think of orbit, cavernous sinus, or skull-based lesions. If there's a problem with more than one of these, lid, pupil, and ocular motility, like for example, ptosis with small pupil is Horner's, ptosis with a big pupil could be aneurysm, or it could be a Guillain-Barré or a Miller-Fisher variant. Any variable diplopia tells you with weakness and fatigue is generalized myasthenia gravis, and I'm sure all the neurologists know how serious myasthenia gravis can be if it's generalized. And any new onset headache, scalp tenderness, pain on chewing, think not just of temporal arthritis, but think of possible aneurysms. And with these words, as Ambika mentioned, I cordially invite all of you to be with us on September 21st and 22nd in Nethralaya for the INOS annual meeting. We have a galaxy of wonderful speakers from abroad as well as local faculty. Thank you so much for giving me the opportunity.
Thank you, sir. That was wonderful. I would say that was a wonderful video buffet or a pictorial buffet. So you had presented it. We'll directly move on to Dr. Anu's talk from here, which is on higher visual functions. This is the last talk before we have a panel discussion on the talks which we have in the eFront part of today's discussion. Dr. Anu, over to you.
Thank you, Dr. Astha. At the very outset, I would like to thank the Indian Academy of Neurology and INOS for this opportunity, and my sincere thanks to my teacher, Professor Vivek Lal, and my dear friend, Dr. Astha. So the topic given to me is higher visual pathway. Is my screen visible?
Yes, ma'am, it's visible.
Okay. So the outline of my talk would be to first discuss briefly about the important anatomical hubs and their connections in the higher visual pathways, following which I would like to mention the functional importance of these pathways through some case vignettes. So we are all very well familiar with this cartoon. We know that the afferent visual information comes through the optic nerves to the optic chiasm, then the tracts, the geniculate bodies, and then the optic radiations lead this information to the medial part of the occipital lobe, where we have the calcarine cortex, which is also known as the primary visual cortex. What we are going to discuss today is the pathway, the visual pathway beyond the calcarine cortex. So when we talk about higher visual pathways, we, in general, as in neurology, when we discuss a case, we want to know what is the lesion, where is the lesion. Similarly, in a visual processing, we would like to know what is the object that we are trying to see and where is the object that we are trying to see. So the first question is addressed by the ventral pathway, which is shown in green in the right-hand side cartoon, where from the primary visual cortex, which is area V1, the information travels to the visual association cortices and then goes to the downstream pathways to the temporal lobe. So this occipitotemporal pathway is known as the ventral pathway, and it helps to delineate the characteristics of the objects that we are visualizing. We have another pathway, which is the dorsal pathway. So this dorsal pathway would start again from the primary visual cortex to the visual association areas and move towards the parietal lobe. So this dorsal pathway helps us to know about the spatial location and helps us to guide our actions when we are trying to visually reach an object. So a little more in detail, when the information reaches the area V1, the V1 area tries to delineate the borders and the orientation of the image. The information goes to the visual association areas, which further try to see what is the color and start judging the depth of the image. Further downstream to area V4, which is in the lingual gyrus region, more towards the inferior surface where we have the junction of the occipitotemporal cortex, we have discrimination of color. So it is the color center, and we have discrimination of shapes. And then the information also goes to our fusiform gyrus, where we have specialized areas for recognition of faces, known as the fusiform face area, and for words, which is also known as the visual word form area. In the dorsal pathway, the information will go from the visual association cortices to area V5 and area V6, which are areas for motion. So the V5 helps in understanding motion. And finally, the entire sensory spatial information is integrated in the posterior parietal cortex. So let us go through some cases and try to understand what happens if there is a lesion or a problem in any of these areas. So this patient was a 58 years old male, and he came to us with a history of visual problems for last 7 years, which have been progressively increasing. So initially, he used to frequently visit the ophthalmologist, get his spectacles changed, but that was of no use. Of late, he was a smoker, and the wife noticed that when he tries to smoke, he has to identify the head of the matchstick using his hand. So on examination, we found that when confronted with a visual stimulus, he is not able to identify the object. So he cannot, when on showing a pen, he's not able to name that this is a pen. Neither can he tell us that this is used for writing. So when given in hand by palpation, he is immediately able to tell that this is a pen. So when we did an MRI for this patient, he had atrophy in the posterior brain regions. So it was a posterior atrophy involving the parieto-occipital and the temporo-occipital regions. And on further doing, since we suspected it to be a posterior cortical atrophy syndrome, which most commonly is a variant presentation of Alzheimer's disease, we went ahead with a tau PET, and the tau PET beautifully delineated tau deposits in the occipitotemporal region. So we can see that these areas have brightened up where there was abnormal tau deposition. So he had severe visual impairment. His elementary visual examination was normal. So what did he have? Is it a case of visual agnosia? So visual agnosia is the impaired ability to recognize visually presented objects. when the elementary aspects of vision are intact. So these patients cannot identify objects presented visually, but they can identify them either through palpation or through sound. For example, if you show a key, they may not be able to tell that this is a key, but if they hear the sound of the key, they may be able to recognize. Visual agnosia is further classified into two types, aperceptive and associative. In the aperceptive visual agnosia, the problem is with the basic visual percept, that the patient is not able to synthesize the visual information and the basic geometric relationships as to how they are forming the contour of that object. So when the visual percept is not proper, if we show them an object, they will not be able to identify, they will not be able to copy that drawing, they will not be able to match it to a similar object given in an array of objects. Aperceptive agnosia is usually seen when we have bilateral occipitotemporal lesions, and if single, it is usually on the right side. Then we have an associative type of visual agnosia, where the percept is there, but it is stripped of its meaning. So we all know that our semantic storehouse is in the anterior temporal region, where we store the information which is coming through all the modalities, be it the visual percept, the heard word, and the action that is done by that particular object. So all this semantic knowledge is there in our anterior temporal lobes. So when we see a visual percept, we have to reach that semantic storehouse and evoke that visual memory and tell that, okay, this is this particular object. So when these connections are affected, we get associative visual agnosia. So these patients can see the percept, they can see the object, but they cannot associate it to its meaning. So they can describe the appearance, they can copy it, they can match it to a similar looking object, but they will not be able to name it, not be able to describe its purpose when presented visually. They may be able to do so through other modalities. For example, if a physician were to develop an associative agnosia and he's shown a stethoscope, he'll be able to tell that there is a U-shaped tubing, and then it is connected to a long cord, and then there is a round knob at the bottom, but he will not be able to tell that this is a stethoscope. So associative visual agnosias are usually seen in dominant occipitotemporal lesions when the splenium is intact. Another type of special visual agnosia is prosopagnosia, where perception of faces is impaired. So these people cannot perceive the unique features that distinguish an individual face from others. So they will use other clues, for example, the gait, the mannerisms, the clothing, and the voice. The substrate for prosopagnosia is the fusiform face area, which, as I previously said, is in the inferior occipitotemporal region, and this has a right hemisphere specialization. Although severe typical cases usually happen after bilateral lesions. Close to the fusiform face area, we have the landmark area, which helps us to identify familiar landmarks. So sometimes these patients can also develop visuospatial disorientation due to landmark agnosia. Some of these patients may also have difficulty in identifying special features of objects. For example, they may be able to identify a car, but may not be able to differentiate between different makes. For example, between a Santro versus a Maruti versus a Honda. So these patients can develop such kind of problems also. Again, this, as I said, can be due to problem with the percept, where they have difficulty judging the subtle differences between the facial features which differentiate one face from the other. And this is usually seen in bilateral occipitotemporal lesions as shown in this figure. And sometimes they develop an associative type where they can see the percept, but they cannot encode it to the facial recognition unit. They cannot connect it to the facial memory that this face belongs to this particular person. And this lesion is more anterior and is seen in the right anterior temporal lobe. So we go to another case. A 52-year-old male presents with sudden onset forgetfulness, difficulty reading, and recognizing colors. So when he's shown these numbers, he's able to read them. When he's shown alphabets, he's able to read but makes a few mistakes. But he has a lot of trouble reading words. So when asked to read words, a simple word like Kamal is read as K-M-L. He does it letter by letter and he takes a lot of time. When he's asked to write a sentence, he is able to write a perfect sentence, but a minute later, he is not able to read what he has written himself. So in his words, I cannot read what I wrote myself a minute back. So what does this patient have? This patient has pure alexia, pure word blindness without agraphia. So this pure alexia is usually, this patient had an infarct in the left occipitotemporal region. So this alexia without agraphia or pure word blindness, people lose their ability to read. Rest of the language functions are normal. They will read letter by letter and may have special difficulty with irregular words with handwritten material. And this is usually understood as a disconnection syndrome, and where the problem is in the dominant occipital lobe with involvement of the splenium. And they may have associated problems with color naming. They may have associated object agnosia. Sometimes this pure alexia is also seen with a discrete lesion in the visual word form area. So another patient who comes to us with reading problems for last 2 years, but all reading problems may not be related to a language deficit. This patient again is able to read alphabets when they are written in a small size, but when he is given a paragraph, he feels that the words are moving away and he would jump from one line to the other and again go back to the first line, and he takes a lot of time to read. So when he's shown these disintegrated alphabets, he's not able to read them, not able to identify. When shown the larger forms of alphabets, he is only able to see a part of them, and his answer is very vague. For example, on showing this alphabet, he says that this is a house, this is a cup. He cannot identify bigger numbers amidst an array of small numbers. He has difficulty identifying an Avon's figure. He says that these are T's, but cannot see the A formed by these T's. On showing this cookie theft picture, he can see only parts of the picture, but cannot describe the picture as a whole. For example, his answers are that this is a leech, this is a flag, this is a sea. On showing overlapping objects, again, he is not able to name or identify these fruits, but would say that this is a 0 and this is an M. He cannot count dots. He can recognize colors, but he cannot read Ishihara plates. On asking to copy, he copies only a part of the number, but he can recognize basic shapes. So this patient is missing the forest for the trees. This was a case of simultaneous agnosia, where this patient had difficulty attending to simultaneous stimuli. So on doing, this patient again was suspected to be a case of posterior cortical atrophy, and on FDG PET, we found posterior hypometabolism. There was hypometabolism in the parietotemporal regions. So simultaneous agnosia is one cardinal feature of the syndrome known as Balint syndrome. Balint syndrome has two other cardinal features in the form of optic ataxia and oculomotor apraxia. So these patients have a normal elementary vision. Their ventral stream functions are normal. They can see objects, they can recognize objects, but they cannot disengage or shift attention to different parts of a visual scene. So these attentional mechanisms are profoundly disrupted due to bilateral posterior parietal involvement. So in optic ataxia, what happens is that there is impaired motor reaching under visual guidance. So when asked to hold an object or to take an object with one hand, the person will outreach that object. And sometimes this may be apparent only with the contralateral hand in the contralateral visual field. So it is important to test both hands and both halves of the visual field. And how do we differentiate it from cerebellar ataxia? If we ask the person to close eyes and touch his or her own nose, the movement is accurate, because that does not involve visual guidance, that will involve proprioception. Another feature in these patients is ocular apraxia, where they cannot generate saccades on command, but their reflexive saccades are okay. So they cannot direct eyes to a visually presented target. Or if they do so, the saccades will be inaccurate. And then, as I said, simultaneous agnosia, where they perceive the local items but not the global scene. So the usual complaints in history may be reading difficulty finding objects when there is a clutter, for example, may not be able to find a particular utensil in a refrigerator. They may get lost while reading text. They may get disoriented in crowded places. So this is the usual history that we should look for in these patients. So this was one of our patients who had PCA. And again, you can see the hand outreaches the pen, but the movement when she touches her nose is perfectly fine. And she had fixation of gaze. So as I said,
Dr. Anu, we'll wind up
yes,
the.
yes. So this was the last case, and we can go on to the conclusion. So we can conclude that we have two distinct pathways: the ventral for object recognition, the dorsal for spatial cognition. Lesions here will affect vision in nuanced ways which are specific to the function of that particular area. Patients may not be able to accurately describe these symptoms. You need to take a good history. A cursory examination will fail. The examination has to be targeted. The deficit should not be explainable by elementary vision loss, and sometimes these patients may fail on the routine tests, and you'll have to do special tests like the preferential looking test for testing visual acuity. And you have to make sure that the patient is attentive, listening to you, understands you, and his general semantics are intact before you label the patient as agnostic. So with this, I finish my talk. Thank you.
Thank you very much, Dr. Anu. I think thank you for comprehensively telling us about this very difficult topic. Higher visual pathway is not easy to cover within 15-20 minutes. We directly move over to the panel discussion on these efferent pathways and higher visual functions. We have a few questions for the expert panel who's with us today. And we have Dr. Jasprit Sukhija, who's the professor of neuroophthalmology in PGIMR Advanced Eye Center in Chandigarh. We have Dr. Monica Singla, who's professor of neurology in Dayanand Medical College, Ludhiana. And we have Dr. Shweta Charasia, who's also the associate professor of ophthalmology in Advanced Eye Center. And she has various publications and awards to her fame. So we'll directly go up with the questions which we have for them. So Dr. Sukhija, sir, how would you usually differentiate between inflammatory cause from the ophthalmological cause, which I mean to say is, how do you differentiate an infiltrative or a compressive or an inflammatory cause quickly on the OPD basis? What would you suggest to the neurologists?
I mean, that last slide of Dr. Naveen probably summed it all. The dangerous signs when you are dealing with the cranial nerve palsy. So probably the age is one of the most important things. So if you have a young adult probably with a cranial nerve palsy without any risk factors, probably that's a red flag. You will need to investigate, especially in children. If you come across they have, you can say, a slowly evolving palsy, and you have your pontine gliomas causing a sixth nerve palsy. So I have seen a few cases this way. The other thing is the pupil involvement. The pupil involvement is very important in these cases. So if you just have a microvascular cause of a third nerve palsy, the pupil would be spared. But remember, the rule of the pupil only applies to a complete third nerve palsy. If you have an incomplete third nerve palsy, and if the pupil is not involved, you have to get an imaging done because it might be evolving. So that is the important thing to remember. Then any history of systemic diseases, like patient might have had a stroke previously, or history of any cancer, that's very important. Headache is the most important thing. If it's headache, a severe headache, as was rightly pointed out by Dr. Naveen in his presentation, probably you are looking for a cause which is not isolated. You will need to investigate further. The other cranial nerves, you can say the corneal sensation becomes very important in these cases, because when you have involvement of these patients with a painful ophthalmoplegia, probably we might be dealing with some kind of a involvement of the apex of the orbit or the cavernous sinus. So that is again one of the important things. Then the variation. If there is the double vision is if there's a variation in the diplopia what the patient is seeing during the daytime, again the patient would need to be investigated. So where when we are looking for compressive lesions, probably these are the ones where the pupil would be involved in patients with third nerve palsy. But yes, you have to follow up these patients. It can't be just a rule that the patient comes to you and you can rightly say that the patient has maybe just a neurological cause versus just an isolated microvascular. If you find that the patient is not improving in 2 weeks, probably that calls for imaging in these patients and further workup. So probably these are the few things which would give you a clue to what you're dealing with.
Yeah, I think a similar thing to Dr. Monica. Yes, Naveen sir, sorry. Yes.
There's a very interesting paper which came out in ophthalmology by Madhura Tamhankar and et al. About isolated cranial nerve palsies and the role of neuroimaging. And it was a prospective study where they did a large series of isolated third, isolated fourth, isolated sixth, and a fairly significant number of isolated what we thought of as ischemic third nerve palsies turned out to have some problem inside the brain, whether it was aneurysm or giant cell arteritis, or if you exclude that, some tumor, etc., etc. And the upshot is they recommended doing neuroimaging and MRI with MR angio for all third nerve palsies, irrespective whether the pupil is involved, not involved, partial, total, whatever. And to a certain extent, I think I would agree with that because, the risks of missing out an aneurysm are very high. So unless you happen to be able to be in a situation where you can follow the patient every day, a total third nerve palsy with pupil sparing, you can follow them every day and for the next 14 days to see what's happening to the pupil. I think it makes sense to do an MRI with MR angio in these cases. Sixth nerve also has this issue because although many of them, depending on the age group, of course, but even in the senior population, they seem to have some space-occupying lesions somewhere, whether it's in the orbit or a little further back, etc. So I remember someone told me, I think it's probably a very simplistic way of looking at it, but think of the third nerve as the aneurysm nerve, the sixth nerve as the tumor nerve, and the fourth nerve as the trauma nerve. And consider that as your guideline. I think my index for suspicion and doing an MRI with A for third nerve now is I do it for all patients. For sixth, I would probably follow up a little bit, but be very, very careful and follow them. Anything out of the ordinary, any suggestion of multiple nerve involvements, just image them. And if they can afford an imaging right at the beginning, just do it. Fourth nerve, on the other hand, most of it is either ischemic or it is a congenital nerve palsy or it's an old trauma of some sort which has resulted in it. Those are the ones where you could, if it's isolated, you can follow it up slowly and decide on doing an neuroimaging depending on how the improvement happens or doesn't happen, as the case may be.
I've seen patients of fourth nerve having with myasthenia gravis as well. So, I mean, like you're saying, imaging in everybody, it's like that common saying, you have a Occam's razor and a Hickham's dictum. So it's like you do investigations for everything in all the patients presented with cranial nerve palsy. But then obviously the cost issues come and everything is driven by the cost issues, your clinical suspicion, your follow-ups. So probably all these things are all related to each other and how you can go about investigating the patient.
I would probably say that if you just wanted one thing on a third nerve palsy patient, if you just had to do one thing, well, depending on the cost, I don't know how much these things cost, even a CT angio is enough, just one, that's it. I just want to know whether the patient has an aneurysm or not, that's it. Of course, if you say myasthenia can be present and pretend to be anything. But if you feel someone has a constellation of symptoms which looks like a third nerve palsy with a pupil sparing, I think it's better to scan them.
Yeah. I think I would also think it up in the aneurysm sense, especially the third nerve. And with that, I had a question for Dr. Monica. Ma'am, especially for the neurological causes of diplopia, most of the times we suspect them. When do you do them? Of course, half of it has been answered by Naveen sir and Dr. Jaspreet Sukeja. And what about the forced duction test? Do you send these patients for forced duction test from your OPD? And these two questions, if you could just clarify upon.
Yeah, thank you, Asta. Good evening, everyone, all the panelists here. As you have already mentioned, that Dr. Naveen sir, Jayakumar sir has already mentioned about a lot about the neurological cause of diplopia. But I think as a neurologist, we need to think, first of all, we need to very clear whether it's a monocular or binocular diplopia. When we have ruled out that it is a monocular diplopia, and with few exceptions that it can be because of the occipital epilepsy or infarction or cerebral polyopsia, then we need to look for the causes for the binocular diplopia according to its appearance and accompanying features. So I think for the causes, we need to be very sure if the patient has any ptosis. We need to think about third nerve palsy or myasthenia, any blurred vision, because of the dilated pupil. It can be headache, it can be because of raised internal pressure or aneurysms or even ischemic neuropathies. We know that they can cause headache, weakness, difficulty in swallowing because of myasthenia. And we need to think about these possibilities in these cases. If patient has any temporal headache with pain and swelling, we know that we can be dealing with giant cell arteritis. So according to the etiology, neurologist has to look for the binocular diplopia. And there are some other way of differentiating whether we are dealing with central or peripheral oculomotor palsies. If patient has along with vertigo, dizziness, it can be the central cause. Or if there are as a smooth pursuit movement, skew deviation, saccade palsies, so it can again tell us that it is we are dealing with the neurological causes. But yes, sometimes we do get patients where we have to think that there is some restrictive kind of palsies, cause of binocular diplopia. Though I'm not very fond of this forced duction test, but yes, we take our ophthalmology colleagues' opinion sometimes for this forced duction test, wherever we feel there's some restriction that we cannot very clearly differentiate whether it is the cause etiology of diplopia. Occasionally, I do send, not very frequently. Yeah.
Maybe an ophthalmologist can tell us about this better. Maybe Dr. Shweta, you can just enlighten us about when to send these patients for forced duction test and when to actually send these patients for squint surgery. Patients often come to us asking this. So maybe in the wake of time, we'll quickly expect this answer from you. Because other questions, I would request the panelists to please answer whatever the questions are being asked to them. Yes, Dr. Shweta.
Answering your first question, when should we go for a forced duction test? So in order to, first we should understand why are we doing forced duction test. Forced duction test is generally done to see the tightness of the muscle. Suppose we are dealing with a kind of a patient who is not able to move his eyes, and we want to see whether the patient is not able to abduct the eye because of the tight medial rectus, or whether there is a paralysis of the lateral rectus, or there is a combination of the two. So in such cases, when you are having a suspicion that the medial rectus is tight and the patient eye is not moving because of that, and the patient has already recovered, and then there is a role of forced action. So whenever there is a paralytic squint, to see the restrictive component has set in, or there is a restrictive squint to start with, like a case of floor fracture, whether the patient's eye is not neither able to go up or down. In such cases, forced duction test has a role. Now, coming to your second question, when should you go for when should you go to operate a case of diplopia? So first we should understand that why we do go for surgery in a case of diplopia. We do surgery to expand the diplopia free field. So first of all, the thumb rule is that all the acquired concomitant squints which are stable for 6 months, which are not progressing, which are not showing even the signs of recovery, which are not showing any variability, and all the neurological things have been ruled out, those patients can be taken up for surgery. This is the general rule. The things which are the surgery is dependent on the amount of squint. Suppose the amount of squint is very small, it can be taken care by Fresnel prisms, or it can be taken care by normal prisms. Then what is the cause of the diplopia? If it is like a microischemic cause, it is going to recover on its own. You can wait and watch. Suppose it's a cause, it's because of the compressive lesion, again because of aneurysm, you treat the aneurysm, the diplopia will go off. But in cases of compressive lesions, when they have gone any kind of surgery and they are permanent, they are not recovering, then they will require surgery. Then other thing is the age factor. And again, important factor is where is the diplopia? Is the diplopia is in the up gaze or in the down gaze? Up gaze is not an important gaze. Down gaze is a very important gaze. If the patient is complaining of diplopia in the down gaze, then that patient might require surgery than patient requiring only having diplopia in the up gaze. Then the another important thing is that you should also see whether it's a case of acquired or it is a congenital decompensated cases of diplopia. In such cases, surgery can be done early also. And again, in some cases of concomitant squint can also present with diplopia, like acute onset concomitant esotropia. And after ruling out any neurological lesions in these patients can be taken up for surgery. Even with the botulinum toxin also, these patients can be given early, and surgery can be done after seeing the patient is not recovering after 6 months.
Thank you, Dr. Shweta. I think there are so many other queries which were of course expected, and we are answering most of them online. For the moment, I think we will need to wind up the session since it's already 8 p.m. I thank all of you, and for the closing remarks, I would request Lal sir for his final closing remarks on this session.
So I am so happy to have been part of this program. It was wonderful. Learning is always a never-ending process. And I am really grateful to each and every speaker, each and every panelist, Astha in particular, for having done such a fabulous job. Ambika's hit the ground running with her beautiful talk on, optic neuritis. And optic neuritis is something that never ceases to amaze me. I mean, trying to learn about optic neuritis is trying to swim in the Pacific Ocean. No one will ever be able to complete that swim in one life. You have those outlier cases. There are those who are NMO or MOG or who are doubly negative, and then you really don't know what to do. It is in this kind of a dilemma that, experience comes to the fore. As I say that the clinical spectrum of any disease is like the 7 colors of a rainbow. I mentioned this at Nano. So it's like the 7 colors of a rainbow. And there is this phrase which I always attribute to Einstein: information is not knowledge. The basis of all knowledge is experience. You see, you understand. E is equal to mc square. I don't understand. And Einstein said all this, and it is, esoteric and stratospheric for me. But this important dictum which he stated, that information is not knowledge, the basis of all knowledge is experience, actually boils down to experience in such tough situations when you're faced with a technology crunch. I'm using the word technology crunch, not because there's a crunch in technology at that moment. At that moment, for technology decides to ditch you. I'm going to be NMO negative. I'm going to be more positive. Come on, youngster, get on now with your works. Wear your spikes and see how far you can go. So these are some of the things that are very important. Clinical medicine is absolutely divine, and I can tell you, how many residents have joined Astha? How many are the how many people?
I could actually see more than 200 participants in today's meet, which is a rare occurrence. And now also we have 100 more.
So I'm glad even during IPL times, if it has crossed 100, that is a huge plus for this session. And Anu, thank you so much. Professor Jayakumar, thank you. Dr. Jasprit, Dr. Churasia, Dr. Astha, Dr. Monica, Dr. Sujit, and Virender Sachdeva, and everyone else for making this session a success. I hope this is the first of the many sessions that we should hold together. It is very important, as Professor Naveen Jayakumar said, you are in no man's land. And if you are in no man's land and you don't want to get lost in that no man's land, the only way you can do it is with cooperation. With that, I come to an end. Thank you so much, each and everyone. Have a safe and a very happy weekend. Namaskar.
Thank you so much, sir.
Thank you so much.
Thank you
Thank
all.
you, sir, and
Thank you.
the opportunity.
Yeah.
Thank you, sir.
Have a great weekend.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you. Bye, Asta.
Dr. Nazneen, thank you. Asmita, are we done? I mean, are you
Hello.
here, Asmita? Yes, hi.
Yes.
Thank you, Nazneen. Thank you